All right. Well, thank you so much for joining. We'll go ahead and get started. So we're attending the session, Engaging Health Literacy Partners to Advance Health Equity in Rural Communities, one community's approach to better understanding health literacy in a rural border region. If those of you that are just joining us, thanks for coming. We had a really great start to the day and start to the conversation, and I really love the idea of working better together and creating collaboration amongst our healthcare provider teams, our clinical and our community partners, and really working together to identify new and engaging ways to address health literacy as a means to support health equity. So my name is Dr. Shyla Williams. I'm an assistant professor with San Diego State University, both in their School of Nursing as well as their Imperial Valley campus. And I'm really excited to be here to talk about some of the challenges that we face in rural communities when we're attempting to address health literacy, as a means to advance health equity. Oh, sorry, there we go. All right, so our learning objectives today are really to, examine the challenges that are faced by rural healthcare systems, particularly in my case, rural border healthcare systems, but small community hospitals, small community systems, as they attempt to, support national and international health literacy practices. We're going to talk a little bit about the importance of engaging with current and future healthcare professionals to address health literacy as a health equity issue, and apply the ideas and concepts that I'm going to present through the case study to your own health literacy practices and a means to engage a multidisciplinary health literacy team. So we're going to kind of get started. It looks like I've got right under 100 participants, so that's great. That should give us some really, really good data here. But I'm going to launch the poll, and I've asked a couple of questions that we're going to return to throughout this presentation. So feel free to answer them one by one. Feel free to answer them, all in one shot, up to you. But I'm going to go ahead and launch that poll so that we can get started. Okay. Yes. Okay. So now you should see a poll with a couple of questions. Like I said, feel free to answer them as we go, or answer them all in one shot. Completely up to you. But the first one that I want to know, and it's more just for my own kind of awareness of who I might be speaking with, is where does your health literacy work occur? And I say, I framed it this way because, like for myself, I actually work both in academia and in the hospital setting. However, I find that a lot of my health literacy work occurs more in those community-based organizations and out in the community. So I wanted to kind of know where does this reside for each of you. So if you'll answer that question, I'm just going to kind of give you a brief introduction to who I am and what I'm doing here. Oh, let me go back, sorry. Okay, so I was born and raised in Imperial County, California, also called Imperial Valley. And the best way to visualize where this sits in the United States is kind of where California, Arizona, and the United States border all meet up. It's that little corner right there. That's Imperial County. We were known for our COVID. We were considered the COVID death capital at one point in the United States, just because of the sheer number of individuals we had that were passing away from COVID. So you may have heard of us, but we typically are a very quiet, unrecognizable community just because of our size. I was born and raised here, so I consider myself not only a resident, but really an advocate. I'm a first generation college graduate. And in fact, I'm one of about 6 or 7 of us. I say or because we've got one that's about to defend their dissertation, but there's only about 6 to 7 of us that are doctorally prepared that are trained to do research and trained to really showcase the data that we're seeing from our community in Imperial County. I'm a registered nurse by background, specifically emergency department. I'm a nurse educator. My master's is in nursing education with my doctorate in nursing leadership administration. And then of course I'm a nurse scientist. And I went down that road because I knew the only way that I could get resources to my community was to showcase the data. And I could only really showcase the data if I trained myself in that research process. So here's a couple of different pictures I wanted to share with you. The top one there, we are a largely agriculture-based community. And so things like the county fair are important to our community and are critical to culture and our daily life. I like to show this picture because that's actually my brother right next to me. I'd won a local legends showmanship contest, and he's sitting right next to me in second place. So I told him I'm going to show this as often as I can in my career. The bottom picture here is the Community Education Center that was established about 5 years ago with El Centro Regional Medical Center, which is one of 2 hospitals in Imperial Valley. And really our goal when we established it, that was my kind of first chance to really get to address some of the community education needs. And so we established it with the intent that we would be able to forward patients or refer patients for additional education on their disease process, their plan of care, find new resources, host things like support groups and such. Unfortunately, COVID, because of the impact of it on our environment, that has since closed, but that was kind of my first journey into patient education and figuring out, how this whole health literacy thing worked and how we could best meet the needs of our population. So we're going to take now just a quick look, and I'm hopefully going to be able to share results here. Let me make sure you can see that. Let me reshare my screen. Okay, so hopefully you should be able to see results. If not a big deal, but it looks like about 8% of us are from hospital or acute care setting. 12% of us are from a clinic or an outpatient care setting. 26% split between community-based organizations, and another 20% in government-sponsored agency or programs. 13% of us are from academia or university, and 14% fell into an other category. So really a nice split between all of those areas. And I think it really highlights the fact that we are all attempting to address this in a variety of means. So that's really helpful to know, and hopefully I'll be able to kind of speak to each of these areas as we move forward here. Okay. So I'm going to go ahead and if you did not fill out question number 2, please go ahead and do so. We're going to talk a little bit about prevalence and the prevalence of low health literacy in your community. And this is an interesting thing, as I'm going to explain here in a minute. But if you're not sure what it is, please, don't hesitate to respond, not sure. But I just want to gauge, kind of what our communities look like together. And then we can talk about what I found in my particular community in terms of the prevalence. So if you haven't answered that question, please do, and we'll take a look at those results here in just a minute. So I assume that we're all familiar with low health literacy. So obviously I'm not going to go into explaining what it is and the nuances of it, but I did want to offer up kind of a definition from which I work and the work that I do is grounded in. And so for us, when we look at health literacy, it really is the ability for patients or people, individuals, to understand basic health information, including common medical terms, and interpret the information to make meaningful, informed decisions regarding their health. And so, again, I like to just clarify, this is kind of where a lot of this work comes out of and what we interpret and understand as health literacy to help frame what we're going to talk about for this next little bit here. So low health literacy, we know, research has told us, is a significant factor in a patient's ability to actively participate in their plan of care. If they don't understand it, obviously they can't be an active participant in the healthcare team. It tends to be more common in rural and racially and ethnically diverse communities, more common in communities where education levels are lower, limited English proficiency or English as a second language is present, and more common where populations experience social and economic disparities. And you might be thinking, yes, we know this. Why do you keep, why are you telling me this? Well, I've highlighted some of the critical words here in those descriptions, and it screams Imperial Valley. In fact, when I do the variations of this presentation and showcase some of the work, and I'm doing that for people who live, work, reside, play in Imperial County, they laugh because they're like, yes, that describes us pretty much to a T. And here's a picture. I know, sometimes we try to capture the worst of the worst, but really this is partly what my community looks like, depending on, where you're at. There's very few locations that are, that most people would describe as beautiful. You can see here on the backdrop behind me, this is actually, let me move that way. This is actually the School of Nursing for Imperial County. We live amongst the fields. In fact, it's quite entertaining when they are spraying those fields, because all of those lovely bugs, rodents, everything that lives in the natural environment comes and enjoys our simulation lab. So, this is our reality. This is, the community in which we live in. The other thing I want to talk about is that clinicians are not aware, despite all of the amazing work we're doing. When it comes to the healthcare provider team, we're not aware. We don't know about it. We tend to overestimate our patients' ability, and we really fail to detect when low health literacy is present. And I wanted to test this out. So actually my doctoral work, when I finished out my dissertation, was focused on our medical surgical nursing population in our hospitals, and whether or not they could actively estimate or determine if a patient potentially had low health literacy. And so the interesting part about this is many of these students, because I do teach actively in the School of Nursing, many of these students were my students. And so they've heard me talk about health literacy. And in fact, one of the questions we asked them was, rank yourself 1 to 5. How familiar are you with the concept and the topic of health literacy? And we would have some of the nurses say, oh, a 5, I remember, you talked about this. We looked at who would qualify and who we should be looking out for. And yet 98% of the time they were wrong. They could not predict their patients who had low health literacy. And I think there's a number of reasons for this, right? For one, there's inconsistent predictors of low health literacy. So even in the research, many of these predictors are largely dependent on the population in which that study was put forth. So things like their education level, that's a fairly consistent predictor, but that's not a question that we typically ask in the healthcare environment, particularly in the acute care environment. So we would actually have to be specifically looking for that and queuing our staff up to ask that question. In our just normal, coming into the ER or coming in and being admitted into our medical surgical population, that's not a standard question for us. So we're not going to easily identify their education level simply by working with them. In fact, going back to our healthcare providers overestimating, the only time that they actually accurately identified patients, their health literacy level, was in 2 patients that were very obviously educated. So when I went in and conducted the health literacy assessment, they appeared very put together. They were both white, both about middle age, spoke well, and again, appeared to be very well educated. So that came off, and that the clinician interpreted that as they probably have the ability to, understand their healthcare information. And for those 2, they were correct. But for all of the rest of them, they were not. And in fact, they often, like I said, 98% of the time they were incorrect, and they often severely overestimated by several data points whether or not that patient had low health literacy. The other thing that impacts why clinicians may or may not be aware is that there's limited, if any, curriculum in their academic training, particularly if they had their academic training, meaning med school, nursing school, physical therapy programs, that sort of thing. If it's greater than about 10 years, chances are they did not discuss health literacy. It's only recently emerged as one of our priorities. So if they haven't had it in their academic training, we assume that they have it in their, professional practice. And again, that's not necessarily the case for many professions, particularly when the professional education is being delivered to individuals who may not be providing education on a consistent manner. And then, of course, hurried and impersonal care delivery models, particularly in rural border communities, in rural populations where healthcare organizations are quite literally just trying to keep their doors open. It's quantity versus quality, and they need to get as many patients through as quickly as possible. The other challenge in our particular area is that our primary care provider ratio is about 4,800 to 1, which is significantly higher than national and state numbers, ratios. And so again, we're trying to push a lot of patients through a healthcare system simply to get them the care that they need. And we hear from our patients that oftentimes when they're seeing their primary care provider out in the community, they're literally being told, we'll handle 1 or 2 things today, and that's all we're going to have time for. So when most of my patients who are over 60 years of age or have 5 to 6, multiple major chronic conditions, we can't tackle their entire health history and what they need to do to care for themselves in a 15-minute time period. It's just not going to happen. And so again, clinicians are not aware, and unfortunately, our healthcare delivery model is not set up to give them the time to be able to have that really critical conversation with patients. So let's take a look at our results for our second poll here. I'm going to see if I can't get the results up here. If not, I'll read them. So it looks like many of us, about 15% of those polled, found that their prevalence in their community is 50% or greater, and then it kind of teeters down. But for about half of us, we're not sure what the prevalence is. And I think that is a finding. If we went out and queried providers and health literacy experts and those that work in this space, you're going to find that that's probably true, because it's not necessarily something we're looking for. And I'm going to talk about that here in just a minute. So let me go ahead and flip over to queue you up for question number 3. So if you get a chance, please go in and fill that out. Looking at who are your traditional or typical health literacy partners. And again, we'll come back to that question in a minute. But I want to look at, is the data really accurate? So there are some challenges when we report this data. For one, variability in measurements. So often much of this data is taken from, community assessments or, like the California Health Assessment, which is very broadly put out at the state level. And typically the measurement is very simple, because it's very hard to truly assess health literacy in that type of a survey, in that type of environment. And so often it cues off of questions like, do you find it difficult to fill out a medical form? And you answer yes, no, and then that drops you in the bucket. And again, that's a great way at that level to potentially screen for low health literacy. But really, to determine the actual prevalence, we've got to have a more in-depth. However, that also means more in-depth means more time. And so some of these health literacy assessments are incredibly complex with, 60, 70, 80 questions to really try to get at the heart of whether or not someone has health literacy or not. The other challenge is that in the data, especially in the research population where we're pulling some of this data from, they're non-generalizable samples. So they're largely convenient samples, which for those of you that don't live in that research world means, volunteers. So someone who is willing to participate may not find that, especially when you say, hey, I want to assess your health literacy level. You might find patients are pretty turned off by that, or individuals are. So they're not going to participate. So largely this data is from convenience sample, is from people who are willing to just put themselves out there and answer these questions. And they're often from single sites or locations. And again, if I want to generalize what I'm finding in that data, that's going to be a challenge, because I've got to ensure that my sample is representative of the population at a whole. And I'll give you kind of an example that I found when I started going through the data in my local community. So at the county level, prevalence of low health literacy was estimated to be about 42.3% per the Imperial County Community Health Assessment. And this was just recently conducted. It was at the tail end, fall of 2022. Now, again, when I'm looking at how do I best spend my healthcare dollars, so to speak, or my community dollars, I'm looking at, is health literacy really a challenge for us? And I look at 42.3% and go, yeah, maybe it is, but there might be other, particularly in communities like mine, there might be other very competitive challenges that we could tackle with the very limited resources and monies that we have. And then when you look at it by gender, about half of the males are estimated to have low health literacy and a little under half of the females. Well, when I actually went in and did a study on this, I measured the health literacy level of patients who were interacting in our hospital environment. So patients that were coming in and out of both the inpatient side, which is typically our med surg, our ICU, our maternal child units. as well as those that were in the outpatient setting, so our emergency department and our rural health clinics, I actually found that the prevalence was near to 80%. And again, when I looked at the sample, was it generalizable to the community? It was. So in terms of like things like ethnicity, we had about the same ratio or percentage of Hispanics in our population as we found in the community. The male to female ratio, all of that was pretty representative of the population in general in Imperial County. And again, prevalence of low health literacy by gender, males and females are both significantly higher than what was estimated at the county level. So again, that's the challenge of, is that data actually accurate? And is it accurate in terms of what tool was used to estimate that, prevalence, and then comparing that to the actual, health literacy assessment, a validated, reliable tool that measures the health literacy level. So in terms of interventional challenges, because again, I don't like to collect data if I don't intend to do something with it. One of the great things is, health literacy seems in these last about 10 years or so, and more so in these last just few years, it's finally emerging as a priority. The World Health Organization, the CDC, they're finally calling out and saying, wow, this is a significant thing that we need to address. However, it is emerging as a priority, which means there's now dollars and cents going to it, which also means that the coordination of the effort is limited. And I think this is one of those really powerful lessons learned out of COVID. Obviously, once COVID hit, a lot of I know from the research world, a lot of the resources were really funneled over. Other projects were stopped and the resources were funneled over to attempt to address COVID, whether that was through vaccines or through education or treatment options, which is great because we needed a solution very quickly. However, it also led to a lot of lack of coordination. So many people were trying to tackle it from many different angles. And so, of course, those dollars and cents got spread out rather than using a truly focused means. And so I know as we get further into this and as this priority continues to be a priority, I'm hoping we can see some leverage around that in terms of health policy and in terms of practices, best practices in clinical side of things to make sure that we're really addressing this in a coordinated effort. So again, many approaches, many options. So looking at number 3, our poll results, again, our question, let me pull it up here. So we looked at, who are our typical health literacy partners? About 20% say healthcare providers, 23% says public health professionals, 9% says social services, 11% says nursing. Man, I gotta get my nursing colleagues more to the table here. 1% works with non-licensed healthcare providers, so promotores or community health workers. And that especially in our population, that is going to be critical. And then 30% say they work with community organizations, with 6% saying other. So again, we've got a pretty broad spectrum of who makes up our healthcare team. So let's go ahead. I'm going to remove this. Let's go ahead and launch into, our case study of looking at our non-traditional health literacy partners at a rural border hospital. So I've kind of done a brief introduction, but want to formally introduce you to Imperial County, California. We have a population of about 181,000, give or take, because we are largely agriculture. We do see a swing in our population. We also have the desert. So for those of you that like recreational desert vehicles like quads and such, because we do have a large portion of our community is our sand dunes and our desert areas. Again, that can influx by even 20 to 30 to 40,000, depending on the weekend during our winter months when our weather is very nice. So we typically have about 181,000, but we can swell and take on additional community members depending on the situation or what's happening in the community. We're about 4,500 square miles bordering San Diego County to the east, Riverside County to the north, Arizona to the west, and the United States-Mexico border to the south. And you can kind of see here in terms of just some basic information looking at our, our economic challenges, our social challenges. We rank pretty low or high, depending on what the data point is median household income is much lower than across the nation or in California. We have a higher rate of children in poverty, poverty at all ages, higher rate of disabled individuals, higher rate of uninsured populations. Public insurance coverage for the hospital in which this study was conducted. We actually have about an 84% government funded, meaning Medicare, Medi-Cal, which is Medicaid in California, or a combination of the two. So, you know, largely in terms of reimbursement, very challenging demographics to work with. Very high rate of unemployment, very low rate of high school graduates and those with advanced degrees. You can see about 74% of our children in the school system qualify for free or reduced lunches. You know, you name it, we've got the disparity. And then of course, our primary care provider ratio is incredibly high as compared to California. In terms of health, Imperial Valley ranks about 35 out of our 56 counties in California. We are state leaders for asthma, diabetes, and obesity. And unfortunately, you know, we're leaders in something, but not for the good things. We rank number 52 out of 56 counties for factors that lead to a healthy lifestyle, meaning we have very limited resources that would help contribute to an overall healthy lifestyle for our residents. And despite being recognized really as an agriculture mecca of the United States, we have about 17% of our population that experience limited or low access to food. And what this translates to is about 78,000 of that 181,000 members of our community are living in what is called food deserts. So despite us being surrounded, as you can see in the picture, by agriculture, much of our produce, much of our product leaves our community and leaves us obviously in areas equipped as food deserts, meaning they don't have access to you know, consistent food sources. With all of that negativity, though, we also have some wonderful strengths. We are a very close-knit community. We have a lot of influence from the Mexican culture and the Spanish language. I would choose never to live anywhere else simply because we are strong in terms of our culture and strong in terms of our familial ties. We have very strong programs such as 4-H and FFA. We do pride ourselves on the fact that we are an agriculture mecca and much of our industry is agriculture based. So you don't really go anywhere in Imperial County without either knowing someone, being tied to someone, or yourself working in the agricultural industry. So again, I say all of that negative to say we also have many, many strengths in our community that we love. We can get things done quicker, which is what's really exciting in terms of research and healthcare, is we're able to maneuver. I liken us to a little speedboat versus some communities where it's kind of like operating the Titanic, right? You can't turn fast enough. Well, we can operate as a speedboat and make change very quickly if the resources are there for us to do it. I want to introduce you to our partner agency, El Centro Regional Medical Center. It's a 161-bed acute care facility. It does serve over half of the community's healthcare needs, particularly the needs of those along the United States-Mexico border. It sits about 10 miles from the border, and so anytime that we do have, immigrants or individuals crossing the border who are in need of healthcare services, they come to El Centro Regional Medical Center. We are one of the largest employers in the community, aside from our corrections facility. We, prior to COVID, employed about roughly 1,200 individuals in our community. That unfortunately has since dropped to about 900, but there are challenges. One of the significant challenges for El Centro Regional Medical Center is the city that surrounds El Centro Regional is actually outside of the rural, does not meet rural restrictions or regulations. And so they're actually considered micropolitan. So despite the entire rest of the Imperial Valley being considered rural, including the other hospital that's about 15 miles away from El Centro Regional, we are not. And so it puts us in this really interesting gap of, we're not big enough to play with the big boys in the healthcare industry, and we're not small enough to qualify for the grants and the resources that are available to smaller organizations. So it kind of leaves us in this gap where, we're really challenged to find resources, particularly when it comes to trying to explore things like health literacy. So this pilot project was supported by the National Institute on Minority and Health Disparities of the NIH and under a U54 mechanism. And it was San Diego State's HealthLink Center, which is really exciting because it was actually selected by a community-led initiative. So we had researchers from all across San Diego and Imperial County submit ideas to qualify for this particular funding opportunity. And this project was actually deemed by the community as a priority. And so they thankfully selected it and funded it. And what was interesting was at the time of its selection, health literacy was identified as an organizational priority for El Centro Regional. The challenging part, obviously, is that we required individual health literacy assessment using the newest vital sign is what we implemented. And I'm happy to answer any questions around why we selected that particular tool. There was a lot of thought and intention in utilizing that tool. And our original goal was to actually have nurses assess patients' health literacy upon admission or upon their visit to the clinic in order to capture that data. So we initially were planning to implement in January of 2021. The project was actually selected the summer prior. So as COVID was hitting our community, again, health literacy emerged as an issue, as a challenge for us, and was selected by the community as their top priority. We attempted to implement in January of 2021, but of course was delayed. We are a healthcare facility and one of the hardest hit ones in the country in terms of trying to provide care for our community. And so we had to delay a little bit due to a COVID surge, but we did have about a 6-month data collection period. So COVID wasn't our only issue in terms of rolling this out. And for those of you that have ever tried to implement anything in an electronic medical record in a hospital, clinic, or an acute care environment, there are challenges galore. We thought we had them identified and prepared for, but the challenge with El Centro Regional actually was that they have 9 EMRs. They are in the process of remedying that, but at the time, 9 electronic medical records, which were considered for building. We chose 4, and we actually had to have individuals who were in another electronic medical record or were on paper. We still had some of our clinics on paper, believe it or not. We actually had them have to gain access to the other electronic medical record to enter this data. And so trying to build even in the 4 was very challenging, very costly, obviously, and then the reporting mechanism. So the other challenge with all 9 of these EMRs, they don't talk to each other. So if a patient comes from the ER and is admitted upstairs, that paper record or that record has to be printed off, put in the chart, and then transported upstairs with the patient. So again, there's no connectivity. So we wanted to make sure that when we were doing this, that we could report this information out, that it became a part of the patient's medical record. Some other challenges we ran into is initial leadership bought in, but staff did not. So the higher level leadership, the CNO, thought it was a wonderful idea, implemented it, and staff said, particularly after COVID, they were resilience was gone. They were tired. They said, no, we're not doing this. And so despite even extensive education and training, didn't happen. They weren't going to adopt it. In the middle of all that CNO left. We underwent an organizational restructure, and the new leadership, the new CNO that was brought in, liked the idea, but did not necessarily support its implementation. So she kind of went along with it because it was already in process, but was never truly that champion. And so we had to develop new strategies very, very quickly to collect this data. So one of the nice things is at the same time that this organizational structure was going on, the research clinic from which this study was actually brought in and worked through went under our chief clinical officer. So that became a new organizational sponsor. Nursing said, hey, no, we don't have time for this. We don't really want to deal with this. So they actually volunteered the physical therapy team to implement and to collect the health literacy assessment. I look at that, putting on my healthcare administrator lens, and this was one of the points that I brought up was, wow, that's incredibly expensive. Physical therapy, the physical therapy team is one of the priciest components in healthcare, and they're going to be doing this study. Okay, so the organization signed on. What the exciting part of that was, though, was that the physical therapy team actually embraced it. They thought this was amazing. It was really a new concept for them. So again, engaging those non-traditional healthcare providers was one of those wonderful lessons learned. They were incredibly excited, super engaged. They loved the training, they loved the implementation, and they actually, as we were training them on the concepts of health literacy, they were linking it back to their own education and the services they provide. And I'll show you here in a minute, what that looked like in terms of their feedback. The outpatient departments, however, though, were still a challenge. The physical therapy team does not go into our outpatient environment like our ER and our clinic, so we needed someone else. So we started working with the clinic staff, particularly the medical assistants. Again, we ran into the same issue. They're too busy, it was not important, and they were trying to push patients through as quickly as possible. So we embraced our volunteers, and this is where we really had to get, thinking outside of the box of who else can we bring in to help us through this process. So we engaged our junior auxiliary, which is our part of our volunteer program at El Centro Regional. What's really exciting about this junior auxiliary is they are health profession career path oriented, meaning that most of them are 16, 17, 18, 19, 20 years old who are interested in going into health professions. And so they were incredibly excited, thought not only will this look great on college applications, they were really excited to be kind of involved in this idea of research. And as we gave them this experience and gave them this training, you could kind of see them putting it together like, okay, this makes a lot of sense in terms of, what we're seeing with our patients. Why do they keep coming in? They have been involved in our healthcare spaces for, some of them for a number of years, especially if they were in college and still in the program. And so they were seeing this revolving door. They were seeing these patients come in and out. We weren't solving their issue other than, giving them the tune-up and sending them back out the door. And so they were really excited to embrace this program. And they actually did a really great job. So here's what we ended up collecting. Our target sample size was about 4,000 in the outpatient environment and 500 on the inpatient environment. And why this is important was this was actually based on our 2019 volume data. And so we knew that we could get these individuals. We knew the volume was there, even with COVID raging and the fact that we had transitioned a lot of our services into the telehealth. We were still seeing pretty near these volumes in our clinics. And so they did a great job, particularly in the inpatient environment. So remember, the inpatient environment was our physical therapy team. Out of a total of 909 that we were able to collect, and this was health literacy assessments on unique patients. So 909 individual health literacy assessments on patients. 543 of those came out of our inpatient environment. 524 of those 543, so pretty much the majority, came out of our medical surgical unit, 18 out of our maternal child. And that makes a lot of sense. Even though I would have loved to have seen higher numbers there, it makes a lot of sense from our physical therapy team because they don't typically go into that setting. And so what they were doing is, if they got a minute down in between patients, they'd kind of run over and look for a qualifying patient, and deliver the health literacy assessment. So we did get 18 of them, although I would have loved to have seen more, especially with our challenges with, maternal health complications and the challenges and barriers we're seeing in maternal health mortality. And so would have loved to see more than that. But again, this was convenience and we had to work with what we were dealt. In the outpatient environment, so we started with our medical assistants. We worked with them consistently for about 3 months at the urging of their leadership. No, please continue to try. And so we did. And finally, again, we had to think outside of the box. So our volunteers started in about June. So from about the end of June till the very beginning there of August, they collected 366 total health literacy assessments. Again, a great endeavor. They were dealing with a lot of challenges in both of those environments. For one, because they were not healthcare providers, the healthcare team would not allow them back. So they had to capture these individuals in the waiting rooms, take them over to a secluded area after they agreed to have their health literacy assessed, and then conduct the health literacy assessment. What we found was there were many patients that started the assessment, but again, in terms of just keeping the flow of the clinic, they would get called back into their appointment and then, were escorted on out the door afterwards. So they couldn't return and finish that assessment. The other challenge was the emergency department. Again, our volunteers were 16, 17, 18 years old. So they were very intimidated by the emergency room. It's a very busy place and can be very challenging at times, particularly in high volume situations where kind of that stress and that wait time is up. Patients aren't, happy to participate. They don't feel great. So it wasn't surprising that our numbers were lower in that area, but definitely, again, we had a lot of lessons learned in both of these settings as to how we could do this better if we had to go back and do this all again. So again, going back to engaging that new and that innovative provider team. So feedback and kind of what we heard from both our volunteers and our physical therapy team was they were very excited to participate in research. Historically, and I could talk for another hour on how we established our clinical research unit there, but it did not fully get established until 2020 and was not recognized as an integral part of the healthcare system until last year, 2022. And so this idea of participating in research was actually very novel to the population, very novel to our providers. And so you can see some of the feedback here. They had a better understanding overall of the needs of the community. And so our physical therapist team, one of the feedback we got was, I didn't even realize this was a thing. Now I find myself thinking about every patient I work with and looking for clues that they may have low health literacy. Speech therapist, I've never even heard of health literacy, but it makes sense. Our career path volunteer, I can see where health literacy can be a challenge here. I don't even think my mom could answer these questions since she works in education. And then this helps me as I want to be a doctor someday, and I want to make sure my patients understand what I am telling them. So again, they really engaged in that process. And I think all those that participated in collecting this data left with something valuable, either for their current or their future practice. So big question, did they, keep the assessment? Did they continue it? No, they did not. And there were many challenges to this when we sat down with them and revealed the data that we found. There were a couple of unique challenges that kept us from actually implementing this full time in their practice. One was that, like I said, their 9 electronic health record system is currently being wrapped up all into one. So one healthcare system, one EHR, which is great, and I'm really looking forward to that. However, because of our resources, because of the cost of these EHRs, they had to purchase a out-of-the-box, no frills, no customization option. And so when it came to whether or not we could do this, they would have to have done it on paper, which of course is not a great means, especially if we are trying to streamline and our whole goal is to get everything inside of that electronic health record. This was not a great means to accomplish that. The one good thing that came out of it, though, is they did make a commitment to revamp their educational program, and I'm going to show you some data here in a minute. So the other part of this study was not only to assess the health literacy level of the patients that the organization was serving, but we actually went in and assessed the educational materials that they were using. And again, that's going to get to one of the key points that I'm going to make in terms of how do we address this from that small community rural hospital setting to better address health literacy in the future. They did make a commitment to look at their educational program, including implementing materials and alternative or supplemental products such as video or audio options. However, again, this is where finances for these types of organizations are challenged, and the education department in the general hospital budget is severely underfunded. So any of this work really has to be done by either budget neutral means, which is very challenging, as I'm sure many of you know who are trying to do this work, or it's got to be grant funded. And again, when the skill set in the community is that we don't have as many grant writers as we would hope, or even scientists to do research, then that funding line and that stream is going to be challenged as well. Despite this, though, new opportunities have presented. And one of the key things, so takeaways from this, was our ability to actually partner with academia more closely. San Diego State University and El Centro Regional went after a new mechanism of funding through the NIMHD, and we established the Imperial County Clinical Research Network, which in this particular case is funding 2 pilot projects. One of them in particular is looking at continuous glucose monitoring in rural border populations. And a part of this is going to be a new educational component that we're actually going to build. And so we've actually had the vendor sign on with us that they're going to participate. So they're going to give us access to what materials they currently give patients who receive a brand new continuous glucose monitor. And we're going to make them culturally and linguistically appropriate to our patient population, and then see what type of information and data we learn from that. So again, it wasn't all for naught. We learned a lot. We were able to actually get solid data of what health literacy looks like in our community. And now we can use that data to leverage additional funding and opportunities to engage that part of the intervention, right? We know this now, what are we going to do about it? So kind of getting into the nuts and bolts, I think all of that said, to talk about, organizational versus individual health literacy approaches, and why are rural healthcare organizations struggling with this? So I know, one of the things that I find challenging in our health literacy world right now is the approach and kind of the one size fits all. Well, if organizations would just embrace organizational health literacy, all will be well. And I'm here to tell you that that is not really possible or feasible in small community hospitals like mine. Here back in 2020, it was right prior to COVID. I think we were just hearing the inklings of COVID. It didn't actually hit my community until about a month later. But this was an article in Forbes talking about, 1 in 4 rural hospitals are at risk of closure, and the problem is getting worse. Then COVID hit. And, despite all of the COVID funding that went to hospitals like mine, we were actually left in even more dire straits. And that's exactly what my hospital's dealing with right now. I mean, our CEO is up every day and every night trying to figure out how to just keep our doors open. So the scene hasn't changed. That, COVID actually made it worse for hospitals like mine. And so again, poor reimbursement and pay structures. So not only pre-COVID are we dealing with, in communities and organizations like mine who are largely government funded, poor reimbursement. We don't make back, a penny of what actually goes in. In fact, when I talk to healthcare providers about how really hospitals get paid, they're pretty flabbergasted on what that looks like in reality. They're not money-making entities. I remember having an interesting conversation with our CFO at the time. I worked in the healthcare finance side of things for quite a while when I first came to the organization. And, he was excited because we actually cleared our margin by about $4,000 for that month. That's not a ton of money in healthcare. And that was great. That was a great month, right? So we're not raking, I always tell our healthcare providers, we're not raking in the money here. We're barely keeping our doors open. So when you talk about, things like health literacy programs, they're a nicety in communities and in organizations like mine, not a necessity. And so if that's up on the chopping block compared to something like, emergency services or a service line that potentially is going to make money, obviously it's a no-brainer for the organization. They've got to go with what they can use to fund and keep the doors open. We also have very limited commercial payers, which often helps offset some of these costs. In organizations that have a healthier payer mix, we don't have that. We have a largely government-funded, public-funded reimbursement. Workforce provider shortage issues and rising provider costs. So again, we have the great exodus in terms of healthcare professionals. So it's costing us more to put healthcare providers in our organization. Again, does not lay well to our healthcare margin. And in fact, this is again why many of these rural hospitals are closing, because they can't even afford to put the healthcare providers in the setting. And this goes back to health literacy being a nicety, not a necessity. And lastly, of course, we're paying more due to inflation and economic pressures. So we're paying more for things like food and power and water. And for my organization, we are one of the last city-owned hospitals in the state of California whatever we make is what we can use to pay our bills. We are not funded by any sort of, tax or district or anything like that. So again, hospitals like mine are very challenged with keeping the doors open. The second challenge I think that we're faced in our communities is the industry created materials are missing the mark in our communities. So we rely on things like, industry created packages that we can purchase for our patients. And earlier I alluded to the fact that we went in and assessed the documents in our healthcare system. The language is still too complex. Language and images can be misinterpreted, particularly by different populations with different cultural and ethnic backgrounds. We know this, right? This is not surprising to us in the health literacy world. Translation is problematic. I found this when we looked at English versus Spanish. And you can see down here in the bottom, the teal box there, you can see that even the scores suffered. So in terms of understandability, we were able to understand the Spanish documents more, meaning the knowledge was communicated better. However, the actionability was not. So despite the fact that these documents were translated from English to Spanish, we lost our messaging along the way and our actionability scores were actually much lower. Obviously, education, especially when it's in this kind of out of the box, one size fits all approach, may not be culturally appropriate. And so a lot of times what we find with these types of materials is that they're in English versus Spanish, but the challenge is that, they've done that translation, very technical, in our case, very technical Spanish, which is not the dialect that we speak in our community. But then they kind of slap a picture of someone who, looks like they speak that language on the picture and think that they've now made it culturally appropriate. And it's not, it's missing the mark in almost every, avenue. And then again, most of these materials are designed to be delivered by healthcare providers. And in our current healthcare delivery model in our current system in the United States, that's an unrealistic expectation. We find, and I can just speak for nursing in particular, we find that when a patient is admitted to the hospital, we don't truly start that healthcare education until about 20 minutes before they walk out the door. Why is that challenging? Because those of you that have ever been admitted, whether it was to have a baby or it was a major condition or to have surgery, on the morning of discharge, one, you're excited to get out of those doors. But on that morning of discharge, I think you would probably sign away your firstborn child to leave the hospital. And so that is not an opportune time to do education. They are literally just yesing you to get you to be quiet as a healthcare provider so they can sign their discharge instructions and get out. So the fact that we're trying to do this in busy clinic settings or busy hospital settings is completely unrealistic. And again, we're missing the mark. The other key thing I want to point out, again, as you look at that teal box, is the grade level. So the using SMOG, we were actually able to assess the documents for their grade level. We know sixth grade is about, the average of where we want these materials to sit. Well, when I look at my mean health literacy score for patients who will actually use that material, so those that have hypertension, they scored about a 1.74 using the newest vital sign criteria. You can see that places them kind of in between that limited literacy likely versus limited literacy possible buckets. Again, limited literacy being the key word there. And so I'm now giving those that are probably health illiterate documents that are vaguely understandable, not very actionable, and they're written at a too high of a reading level. I know from speaking with my home health counterparts that are doing follow-up education and follow-up care for our patients that we're discharging out of the hospital. They're going to their home, they're being placed on the coffee table with good intentions, and then within a couple of days they migrate their way over to the trash can, or they end up holding up the leg of the coffee table, right? The patients are not using them, so we're sending them home literally with some pages that aren't effective. So all of this to say, and I hope this is the message that you get, is health literacy really is an ultimate team sport. And that's why I absolutely love this morning, the conversation was started, with how do we learn from each other? How do we engage, the entire system, not just the healthcare industry, not just the community setting, but the entire system to really look at health literacy through a similar lens, strategize ways that we can approach it collectively in a coordinated fashion to really do some good and address health literacy in our communities and across the nation and globe. For us, the volunteers were really critical, and what I absolutely love, going back to my point regarding, healthcare providers really haven't been taught this critical concept, and the reason, why patients can't participate in as a member of their healthcare team. Our volunteers are future healthcare providers. And so really our opportunity to instill this concept and to actually see it live and to interact with it and have that experience, we're hoping really provides some lasting effect on them, so that when they are healthcare providers, hopefully they return to our community and help take care of our patients, that they're bringing this experience with them and will be more cognizant of it. I hope by that time, because some of them are even, med school bound, so we've got a little bit of time. I hope by that point, though, that the system is set up better to assist them in that endeavor and make sure that we're really finding long-term solutions for health literacy in communities like mine and communities, like all of ours. So here's my key references, should you want to know any of them, but that pretty much concludes my presentation. I'd love to open it up to some question and answers. I am going to leave this up, so if you want to reach out and have a conversation, I know you can do it through the conference app, but feel free to email me as well. I'm always looking to stretch my community and stretch my network of individuals doing this work, because I think, again, that collection and that collaboration is so critical. So I'm going to open up my Q&A box, look at some of the questions we have. So the first one up here, and I know we've got about 5 minutes, so I'll try to get through as many of them as we can. Please feel free again to send them in. Happy to talk offline to address them. The first one was, generally speaking, how do you test a person's health literacy? And that's a really great question, particularly if, this isn't a part of your practice, like if you're a healthcare provider. There are many tools out to test or to assess a patient's health literacy. Of course, not all of them are 100% accurate. However, there are many that are valid and reliable that will give you a good sense of where that patient is. And this kind of goes into the next one as to why we chose the newest vital sign as our assessment tool. And so with that, we looked at a number of them. We knew that this was going to be delivered in a very busy healthcare environment, so that limited us already in that delivery. We needed it delivered as quick as possible, but I also wanted to make sure that we had a tool that would give us, a high likelihood of capturing those. So the newest vital sign actually does a really great job of capturing those individuals that are kind of on the edge. They may have low health literacy, and going ahead and kind of dropping them in that bucket. And, my thought process and our collective team thought process was that I would rather put someone in that was borderline, might have, adequate health literacy, and go ahead and meet that need, versus missing them completely and risk losing somebody kind of to that outside world. We were also going into this with the idea that potentially this health literacy assessment tool would be implemented as a part of practice. We talked to a couple of our education teams that were in our system already doing some of the patient education. Like we have a ADA recognized diabetic education program where they focus on using the food label and teaching to a food label. And so they were really floored with the newest vital sign, because that's exactly what it was based on. And so they thought that really kind of, if nothing else, communicated that message to patients that this is important. And, this particular tool can help provide additional information. The other thing that I really liked about it was it gave us kind of two methods. So it gave us, groupings. So we were able to group them into, adequate health literacy, limited literacy, likely or probable. And then we also got a quantifiable number off of it. So we actually were able to look at, how many questions they answered right, and rank them based on that score. And so as we looked potentially in the future at interventions that may help raise the health literacy level of this population, we were wondering if this wouldn't kind of play in later as a means. I know the newest vital sign really hasn't been tested to be kind of a pre and post, and it doesn't really make sense to do it with that, but we wanted to see if we could numerically quantify the health literacy score. So that's a great question, and again, happy to go into that. If you have additional questions, feel free to reach out. I have a whole Excel spreadsheet where we did a lot of comparing and contrasting of the various health literacy assessment tools that are out there. Again, question, what tool did you use to assess your patient education? We used the PMAT and SMOG. PMAT is the Patient Education Material Assessment, and it's put out by AHRQ. It's a free resource out there, so that was really interesting to see, and it's been well documented in other studies as a means to assess the understandability and the actionability of our materials. And then we use SMOG, the simple measure of gobbledygook, to actually determine the reading level of our documents. So again, another really great question, and felt very comfortable using those tools. And how do we ensure, this is another question, how do we ensure that healthcare materials are culturally appropriate if we do not participate in the culture we are trying to reach? That's a really, really great question, and probably be my final question of the day. So I think it's a great one to focus on. This is a conversation that I have with a lot of researchers in particular who are trying to tackle this. And the idea being that you need to really work with the population that you're going to use them in. One thing that we found in some of the other work that I've done is that, we as researchers, as healthcare providers, as clinicians, look at some of these materials and think, man, they are fabulous and they're going to be so helpful. And we would take it in front of these populations that we intended to use them with, and they can't understand it, and it doesn't work, and the communication is lost, the message is lost, the pictures don't make sense to them. And so I think it is really critical to involve that target population with the materials, involve them in that process of assessment, a process of selection. And that's one of the things that, as I went back to the hospital, they're looking at revamping their education. They're looking at a new vendor potentially to bring in. And that's part of what they're doing, is they're going to bring in their patients to actually vet those materials with them. And I think that is critical. Look for the ones that you're actually going to be using this in, engage them in that process, allow them to have a voice, and make sure that what you're choosing for them and to be used by them is, going to work for them. So with that, I think we're all out of time, but thank you so much for the questions. If I didn't get to your questions, please feel free to reach out to me. I'm very happy to answer via email or through the conference app. So thank you so much for sticking with me for this hour. Have a great day.